My name is Rao, and I'm an internal medicine resident at Orlando Health. It is an honor to have the opportunity to present this case to the American College of Physicians. My poster is titled, The Race for a Diagnosis, a Rare Case of Racemose Neurocysticercosis. This is the case of a 47-year-old female who recently immigrated from Mexico with a past medical history significant for hypertension and hyperlipidemia. The patient was brought to the emergency department by her family after being found unresponsive. Her family states she has had headaches intermittently for the past 2 months with associated nausea and vomiting. On admission, her vitals were stable and her exam was significant for encephalopathy with slurred speech and compression of a third cranial nerve with ophthalmoplegia. A CT head revealed a hyperdense lesion along the right ambient cistern and medial aspect of the right temporal lobe. An MRI of the brain was then ordered that showed bilateral thalamic ischemic strokes and further characterized the enhancing cystic lesions. These findings were concerning for neurocysticercosis versus a neoplastic etiology. A lumbar puncture was then performed with a CSF analysis revealing mild lymphocytic pleocytosis with 40 white blood cells, 94% lymphocytes, and 1% eosinophils. The protein was 48 and the glucose was 55. The patient's serology for cysticercosis IgG returned positive. She was started on treatment with dexamethasone 4 mg every 6 hours, levetiracetam 500 mg twice a day, and albendazole 600 mg twice a day. After extensive discussion between the neurosurgical and infectious disease teams, a biopsy was not performed due to the location of the intracranial lesion being too high risk, and a ventricular peritoneal shunt was not placed as the patient had no signs of obstructing hydrocephalus. The patient improved and was discharged to rehab facility. After 1 month from being discharged, a repeat MRI showed resolution of the cyst and surrounding inflammation. Here are the pertinent labs. As you can see, he has a mild lymphocytosis 11.8, a normal eosinophil count, mildly elevated liver enzymes that can be nonspecific in neurocysticercosis, and a lumbar puncture that we reviewed in the case presentation. As we move forward in the imaging, in Figure 1 we see a non-contrast CT head showing a hyperdense lesion along the right ambient cistern and medial aspect of the right temporal lobe. The lesion measures 1.8 by 0.8 centimeters. Figure 2 is an MRI of the brain with and without contrast that shows bilateral thalamic ischemic strokes. Depicted is the focal restricted diffusion anterior aspect of the left thalamus. There is also a sub-centimeter focus of restricted diffusion in the right medial thalamus. Figure 3 and 4 are from the same MRI brain with and without contrast. Figure 3 is cut in the coronal view and Figure 4 is in the axial. There is a mixed proteinaceous septated fluid collection located within the intrapeduncular cistern, the right ambient cistern, the right prepontine, and the right quadrigeminal cistern. This abnormality measures the maximum dimension from the right ambient cistern to the right prepontine cistern of approximately 2.9 centimeters. This fluid focus surrounds the bilateral ocular motor nerves and the bilateral abducens nerves, the right trigeminal nerve, and the right trochlear nerve. This abnormality produces mild mass effect on the mesial right temporal lobe. This is the discussion portion. Neurocysticercosis is an invasive parasitic infection of the central nervous system caused by the larval stage of tapeworm Taenia solium. The life cycle begins when an individual consumes the tapeworm by eating raw pork meat. The percolatas and the eggs of the tapeworm are eliminated in the human feces. If that person were to not wash their hands and contaminate someone else, the next person will ingest the eggs through fecal-oral contamination. Once ingested, the gastric acid turns the tapeworm's eggs into oncospheres, and a parasite crosses the GI system on its way to the vasculature. This disease is endemic to South and Central America, Southeast Asia, China, and Sub-Saharan Africa. It is becoming more prevalent in the United States due to high volumes of immigration from these endemic areas. There is an estimated 1,000 new hospitalizations for neurocysticercosis in the U.S. each year and is one of the most common causes of acquired seizures in endemic countries. Symptoms range from subclinical headaches to seizures, cerebrovascular events, arachnoiditis, vasculitis, elevated intracranial pressure, and subacute to chronic hydrocephalus requiring CSF diversion. The presentation can prove to make the diagnosis difficult, therefore detailed history, quality imaging, and both serological and CSF testing are vital. Neurocysticercosis is classified as either parenchymal or extraparenchymal. Extraparenchymal neurocysticercosis mainly involves the subarachnoid, meningeal, and intraventricular space. It is more severe but is far less frequent and much less studied than parenchymal neurocysticercosis. The Racemose variant of extraparenchymal neurocysticercosis represents a particularly aggressive infection and is associated with relatively increased morbidity and mortality and decreased responsiveness to medical treatment. The word Racemose itself is Latin and means having the form of a cluster. In this disease, it refers to an aberrant proliferating cestode larvae present as multiple non-encapsulated cystic membranes that bud exogenously, giving a multilocular cystic appearance resembling a bunch of grapes. These are typically located in non-confining areas of the brain, such as the cisterns and the basal subarachnoid space. No consensus exists regarding the optimal treatment of Racemose neurocysticercosis, including duration of antihelmintic treatment and the role of surgical intervention. Here are my key points from the presentation. Neurocysticercosis is becoming more prevalent in the United States due to high volumes of immigration. The extraparenchymal form is less common and harder to treat. The Racemose variant of extraparenchymal is even more aggressive. Given the severe complications, early recognition and prompt medical management is vital when neurocysticercosis is suspected. Vigilant clinical and radiographic monitoring and response to treatment is imperative to reduce neurologic sequelae and infection relapse. Here we have my references. Thank you, and stay safe.